Google says its AI just matched 21 primary care doctors on disease management. Not on a question-answering benchmark, on actual long-term disease management tasks. Care planning, follow-up, guideline adherence, treatment refinement. They published it in Nature in June 2026. Microsoft announced a diagnostic orchestrator that outperformed physicians. OpenAI launched HealthBench. We are now watching, in real time, the world's 3 largest AI labs compete directly in clinical medicine. And as a physician, my job right now is to give you a clear-eyed read on what those results actually mean, and what they do not mean. So that is what today's episode is. Let me give you the strategic context for why Google, Microsoft, and OpenAI are all moving aggressively into clinical AI at the same time. It is not because they suddenly care about healthcare. It is because the clinical AI market is, by any measure, the most defensible and most lucrative market for large-scale AI deployment. U.S. healthcare is $4 trillion annually. Administrative costs alone are conservatively $800 billion. The documentation burden is enormous, the data is rich, and the organizations, health systems, insurers, physician groups have large technology budgets and willingness to pay for software that works. The race is also about data. Clinical data is among the most valuable and hardest to replicate datasets in existence. A model trained on structured clinical outcomes from a major health system has a competitive moat that is very difficult for a smaller competitor to overcome. The big labs are racing to build those relationships and access that data before the market consolidates. That context matters when you are reading the announcements. These are not purely scientific publications made in the spirit of open inquiry. They are competitive positioning moves by companies with enormous financial stakes in the outcome. That does not make the results false. The Nature publication process is genuinely rigorous, but it means the accompanying press releases require careful reading. With that caveat stated, let me take each of the 3 major announcements in turn. Google's AMIE, Articulate Medical Intelligence Explorer, has been in development since at least 2023. The initial AMIE paper demonstrated that the system could conduct a clinical history via text and reach diagnostic accuracy comparable to primary care physicians. That work was impressive but also limited. Single encounters, text-based, focused on diagnosis rather than management. The June 2026 Nature paper extends AMIE significantly. The title is about disease management, specifically the ability of the system to support long-term care for chronic conditions, not just one-off diagnosis. The evaluation involves simulated long-term patient scenarios, where the AI must not just diagnose but plan, monitor, adjust, and communicate over time. The headline result is that AMIE matched 21 primary care physicians on the combined evaluation and exceeded them on specific dimensions. Plan preciseness and guideline alignment in particular. That is a meaningful result. Guideline alignment is measurable. Plan preciseness is operationalizable. Those are not subjective impressions. What I want to examine closely is the evaluation methodology because the framing matters enormously. The comparison is 21 primary care physicians, not specialist physicians, not subspecialists. Primary care physicians are extraordinary clinicians doing one of the hardest jobs in medicine. But the comparison is not 21 academic internal medicine attending physicians at a major research center. The population of physicians you compare against determines the ceiling you claim to match. The scenarios are simulated patient cases, not real patient encounters. The same limitation we discussed in episode 3 applies here. Simulated cases are cleaner than real ones. The patient who presents with 3 vague symptoms and a family history you only learn about in the 5th message is underrepresented in carefully constructed evaluation scenarios, and the evaluation is by structured rater assessment, not clinical outcome. Matching on guideline alignment and plan preciseness as rated by structured assessment does not mean AMIE produces better patient outcomes. That evidence does not exist yet. Google has announced that a nationwide real-world virtual care study is now running. That study will produce the outcome data. We should wait for it before drawing strong conclusions. The data we have is genuinely encouraging. It is not yet the evidence that clinical decision-making should change based on AMIE, and Google, to their credit, has not claimed that. The Nature paper is science. The press coverage is where the overclaiming lies. Microsoft's MAI DxO, Medical AI Diagnostic Orchestrator, is a different architectural approach from AMIE. Rather than a single large model trained for clinical tasks, MAI DxO is a multi-agent system. multiple specialized reasoning agents, each examining a clinical case from a different angle, with an orchestrating layer that integrates their outputs. The May 2026 announcement was not a Nature publication. It was a Microsoft blog post with preprint research. The headline claim, MAI DxO outperformed individual physicians on complex diagnostic cases. The key word is individual. Primary care physicians are extraordinary clinicians doing one of the hardest jobs in medicine. Multi-agent systems have repeatedly demonstrated that diverse debating agents outperform individual expert reasoners. This is not surprising. The question is whether MAI DxO outperforms a physician team using standard consultation practice. The evidence for that claim does not yet exist. What I find most significant about MAI DxO is the architectural choice, not the benchmark claim. A multi-agent diagnostic orchestrator is exactly the kind of system that maps to how complex medicine is actually practiced. Difficult diagnoses are resolved through consultation, multiple specialists with different knowledge bases, debating the evidence, reaching a synthesis. If MAI DxO can replicate that consultation architecture in an automated way, that is genuinely useful for cases where the consultation is not available. Rural practices, underserved settings, middle-of-the-night emergency decisions. The AI dispute resolution mechanism we discussed in Episode 3 from the AI Hospital paper is the academic precursor to this commercial implementation. The Alibaba/Fudan research showed that collaborative multi-agent reasoning improves diagnostic accuracy. Microsoft has productized that finding. OpenAI's HealthBench is a different contribution entirely. It is not a clinical product, it is an evaluation platform. HealthBench Professional is the hard version, complex, ambiguous clinical scenarios where the correct answer requires genuine clinical reasoning. The benchmark has already spawned a set of AI systems trying to score well on it, including MDIA, a multi-agent diagnostic intelligence pipeline, building as a 7-node specialty-routed directed acyclic graph, scoring 0.6272 on HealthBench Professional. This changes everything. The significance of HealthBench is that it creates a standard against which all clinical AI claims can be measured. Prior to this, benchmarks were fragmented. Clinical AI benchmarks were fragmented, every company cited the benchmark on which they scored best. A standardized OpenAI maintained benchmark that is genuinely hard changes the evaluation landscape for the better. Even if you are skeptical of OpenAI's commercial interests in clinical AI, the evaluation infrastructure is a public good. Let me give you my unfiltered read on the big lab landscape because I think the physician perspective is missing from most of the coverage. First, the progress is real. I want to be clear about this because I think reflexive physician skepticism, AI can never replace clinical judgment, has prevented the medical community from engaging seriously with work that is genuinely important. AMIE's performance on guideline alignment and plan preciseness in a well-structured evaluation by a credible publisher is meaningful progress. MAI DxO's multi-agent architecture represents a genuinely novel approach to diagnostic reasoning. HealthBench raises the evaluation bar for the entire field. These are not marketing stunts, they are scientific contributions. Second, the comparison populations in these studies are almost always smaller than the narrative implies. 21 primary care physicians, individual physicians rather than teams, simulated patients rather than real ones. These choices reflect the genuine difficulty of running clinical AI evaluations. Those choices are not dishonest. They reflect the need for consent and oversight, but it means claims are potentially competitive only under controlled conditions. Third, the big labs are not building for my practice. Google AMIE is being evaluated in a virtual care study. The target deployment is telehealth, text-based, remote, high-volume primary care. Microsoft is building for enterprise health system deployment at Epic and Cerner scale. OpenAI is building evaluation infrastructure and is in early discussions with health systems. None of them are building for a specialty regenerative medicine practice in Atlanta with 45 patients a week and highly individualized protocols. This is not a complaint. It reflects rational business decisions about where the volume and the margin are. Primary care telehealth is enormous. Enterprise EHR deployment is enormous. Specialty medicine is not a priority target for a trillion-dollar lab. What it means for practices like mine is that we are not going to get an off-the-shelf Google or Microsoft product that solves our specific workflow soon. We are going to need to build on the architectural work. the medical OS layer, the OpenClaw permissions model, the skill library approach. How and compose our own operational stack. That is more work. It is also more control. Here's my practical guidance for physicians and healthcare operators watching the big lab race. Believe that large language models have achieved clinically meaningful performance on structured diagnostic reasoning tasks. That is now well supported by multiple credible evaluations. Believe that guideline alignment and documentation quality are areas where AI tools are already competitive, with or superior to average physician performance in controlled conditions. Believe that the technology is advancing fast enough that practices should be actively planning for integration, not waiting for a mature off-the-shelf product. Wait for clinical outcome data. The step from AI performs well on structured evaluation to AI improves patient outcomes in real deployment is the most important step in medicine. We do not have it yet. The AMIE real-world virtual care study will produce some of that data. Hippocratic AI's health system deployments will produce some of that data. Until we have outcomes data, no clinical AI tool should be positioned as a decision-making authority, only as a decision support tool. Wait for rigorous evaluation in specialty medicine. The current benchmark landscape is heavily weighted toward primary care and general internal medicine. The evidence for clinical AI performance in regenerative medicine, musculoskeletal care, PM&R, and longevity medicine is essentially non-existent. That is my specialty, and I am not going to deploy a tool in my practice based on primary care evaluation data. The race between Google, Microsoft, and OpenAI in clinical AI is genuinely exciting. It is also genuinely incomplete. The honest physician response is to follow it closely, understand the methodology behind each announcement, and build toward integration with appropriate humility about what the evidence does and does not support. 3 of the world's largest AI companies are now in direct competition in clinical medicine, producing peer-reviewed research, deploying in real health systems, and beginning to generate outcome data. That is a materially different landscape than it was 2 years ago. The trajectory is toward tools that will, in controlled deployments, perform comparably to individual clinicians on structured clinical tasks. The question is how fast that trajectory translates into tools that are deployed safely and effectively in the full diversity of clinical practice. My read, the performance is real, the deployment is early, and the specialty medicine gap is large and unexploited. For a practice like Pravida, the opportunity is to build ahead of the curve, not by deploying Google AMIE or Microsoft MAI DxO tomorrow, but by building the architectural foundations now so that when those tools mature, we are ready to integrate them. Episode 7 is the one I think will resonate most with clinicians in complex medicine. We talk about the long tail, the patients that today's EHR systems and today's clinical AI products are simply not designed to handle. The multi-system, multi-year, multi-provider patient. The regenerative medicine patient who has seen 5 specialists and failed 3 treatments. The patient whose complexity is the reason they came to a place like Pravida in the first place. And I will show you why agentic AI, specifically the OpenClaw longitudinal memory architecture, is the first technology designed for that patient rather than around them. I'm Dr. Trevor Turner. This is the Medical Operating System.